Low urinary tract obstruction or dilation. This is an image of a megacystis. It's an ultrasound performed before 14 weeks of gestation. What do we have to consider when diagnosing a megacystis? The first thing to assess is the diameter. Megacystis is defined as a bladder of more than 7 mm. If this measurement is of more than 15 mm, it's a larger measurement and therefore the prognosis and risk are different. In the situation from 7 to 15 mm, there's high risk of chromosomal anomaly, not that high in larger bladders. We have to explain to the parents that in case of a bladder from 7 to 15 mm, there is 90% of a spontaneous resolution. But it's not the same with bladder greater than 15 mm. And in the case from 7 to 15 mm, it is rare that they have an obstructive uropathy, called LUTO, low urinary tract obstruction. On the contrary, when the bladder has more of 15 mm, there is high risk of obstruction. When we reach 15-16 weeks and we still see a megacystis with normal amniotic fluid, we have to consider it as well megacystis. Here we can see this typical image of the posterior urethra, keyhole sign, which is typical of an obstruction in the urethra. Color Doppler will help us to identify the bladder, and that what we are seeing in between is the bladder, and we also must assess the kidneys. When facing a megacystis, we can classify it as non-obstructive anomaly or secondary to urethral obstruction, what is called LUTO. In which case, we will suspect a non-obstructive uropathy. In case as a female, with normal amniotic fluid, megacystis but lobulated, with folds and irregular. In case we do not see the keyhole sign, with less hydronephrosis, and when there is other malformations or with abnormal karyotype. In all these cases, we won't think in an obstructive pathology. The most frequent etiology is the primary Prune belly. We also have to rule out the presence of neurogenic vesicle atony, a bilateral vesico-urethral reflux, cases of megacystis, microcolon hyperperistalsis, or cloacal anomalies. While in the cases of megacystis secondary to obstructive pathology are generally males with persistent oligohydramnios with a hyperdistended bladders, keyhole sign is usually seen, bilateral hydronephrosis, and in general conditions there are no other malformations and with normal karyotype. Typically affects males. In 90% of cases, the main cause is the urethral obstructive, in majority of cases due to the posterior urethral valves. But we do have to remember that if the diagnosis is before 15 to 16 weeks, until 50% of cases will correspond to urethral atresia or stenosis, and this has an important prognosis factor regarding also the fetal therapy. We also have to comment that obstructive ureterocele is an important cause of urethral obstruction that we have to take into account in the diagnosis. The natural history of LUTO is a progressive dilation of the superior urinary tract, which can condition a renal dysplasia and therefore a renal failure. Secondarily, having a complete obstruction will consequently cause a severe oligohydramnios and therefore severe pulmonary hypoplasia. We have a perinatal mortality rate of around half of the cases, but if the early oligoamnios takes place, then the mortality rate is around 90% of cases. In case the child survives, half of the cases will present a chronic renal failure with necessity of dialysis or transplant in the infant period, and also some functional anomalies as the emptying and continence, which should all be discussed with the parents when making this counseling. Which will be the clinical management once LUTO is diagnosed? Confirm if this anomaly is isolated. We have to rule out if there are other malformations. Perform an echocardiography. Perform the genetic study. In second place, we should assess the renal function, which can be made through ultrasound or by blood and urine sample. Systematic reviews have been published which evaluate the use of antenatal ultrasound to predict the postnatal renal function, and they all reach to the same conclusion. There are two signs that are the most adequate ones: the amniotic fluid and the appearance of the renal cortex, in which the echogenicity or the presence of renal cyst will be assessed, and are the better predictors of this function. On the other hand, the hydronephrosis doesn't have much value, but it is true that when the cause is a urethral obstruction with lack of amniotic fluid, the quantity of amniotic fluid won't be useful, so it will be more difficult, and we should in consequence assess the renal function based in the appearance of the kidneys. Regarding the analysis of urine done through vesicocentesis, the determination of sodium or chloride below this value will be of good prognosis, but these values are useful in fetuses of more than 20-22 weeks. The urine in fetuses of 16 weeks are hypertonic, and therefore it is normal to have sodium of more than 100 or a chloride of 90, and increased osmolarity, so it won't be useful to assess renal function in early obstruction. Additionally, if we evaluate the urine, it's important to perform serial vesicocentesis within 40 to 72 hours, so we tend to evaluate the trend evaluation of 3 serial vesicocentesis, so it's more the tendency than a cutoff with a single puncture. We also have to remember the variations depending on the gestational age, as we mentioned before. In this video, we can see a case after a vesicocentesis in which the bladder was ruptured and it created an ascites in the fetus surrounding the bladder. And if we had the chance to perform a fetal therapy, we missed it due to the ascites as a result of a complication of the vesicocentesis. Finally, we have to do a follow-up. Once we rule out the associated anomalies, once we evaluated the renal function, and by ultrasound we think it's normal, and in every follow-up we have to assess the quantity of amniotic fluid and the possible renal failure due to the progressive hydronephrosis. The clinical options are, first, the expectant management. If it is a pregnancy of less than 20 weeks, it has 90% of mortality rate. Therefore, an option that we have to discuss with the parents in an honest way, explain the poor prognosis, and if the legality of each country and the committee allows it, let them know that they have the possibility of termination of the pregnancy. And, in selected cases with information the parents can think of accepting a fetal therapy, we will always propose it as transient management of the pathology, and in which if it doesn't work, we could return to option number 2. And classically, with this therapy, we will consider in the case a luteal is considered treatable, which will be basically those of suspicion of posterior urethral valves, and therefore should be male fetuses with megacystis, with keyhole sign, with upper tract dilation, nor echogenicity nor cortical cyst, reduced amniotic fluid, and there is no other anomaly. This was the first case of fetal open surgery in the history of humanity. It was a posterior urethral valve case in California. They made 3 to 4 cases, but all these had poor outcomes due to the aggressiveness of open surgery, and this therapy was abandoned, so the amniotic-vesic shunt was then considered. The vesic-amniotic shunt started 30 years ago. More than 400 cases have been published. Systematic reviews and meta-analyses have been made. So, what can we tell the parents? Half of the cases will have complications. The fetus itself takes it out, so we have to put it again. The collocation is not easy, and globally, the survival will be of half of the cases, and from this half of the cases will end in chronic renal failure, severe in the first year of life, with need of transplant or dialysis, and the other half will have a normal renal function, but will have poor vesical function, because it's like the fetus had a bladder catheterization throughout the pregnancy. It doesn't have a normal vesical function, therefore, the therapy of vesicoamniotic shunt is not easy to do, and a normal renal function is expected between 25 to 30% of cases, and generally with poor vesical function. Due to the poor outcomes of the vesicoamniotic shunt, the fetal cystoscopy has taken the place. Less than 100 cases have been reported. We are one of the groups, and it seems there are less complications and higher rates of survival with higher rates of normal renal function. And important, a better vesical function, because in these cases it is a single intervention and the fetus is emptying and filling the bladder in a physiological way. So it is considered that with the cystoscopy they can have better survival rates with better vesical function. There are preliminary data because the global experience is of less than 100 cases, but the tendency seems like it has better results in relation to the vesicoamniotic shunt, although the results are not spectacular, and in that way we have to tell the parents. Therefore, when having a treatable luto, in which we find a megacystis due to urethral obstruction, and we think that the most probable cause are posterior urethral valves, we will offer the option of cystoscopy. This is a case of a paradigmatic case, in which we see a megacystis due to luto. Here you can see the giant bladder with the keyhole sign, which corresponded to posterior urethral valves. This is a cystoscopy. We enter with the trocar directly into the bladder. We see the hypertrophic vesical mucosa, Phyty mucosa. Now we are getting close to the urethral dilation, and here we can see the verumontanum and the middle, which indicates that we are in the posterior urethra. This is the trigon, and here we can see the obstruction. This should be open, and it's occluded. Due to this membranous tissue, anomalous tissue. So we advance the laser, and at both sides of the verumontano we try to make 3 to 4 holes till the urethra is permeable. We also have to count on the necrosis around each hole made with laser. So at 3 to 4 days it will be about 3 to 4 millimeters of hole, which will allow the continuity between the bladder and the urethra. And in this case, in which we advance the fetoscopy through the bladder, again fighting bladder, we advance the fetoscopy till the urethral zone. We see once again the verumontanum, and here we can see a tiny hole. We are at the urethral zone. It's not a normal urethra, and this tiny hole that suggests there is some communication but ineffective. And we can see how this laser fiber is of 0.4 millimeters, and the hole is smaller, so it is insufficient. So in this case, in which we see this insufficient hole, we rule out the diagnosis of posterior urethral valves. This is a case of stenosis or urethral atresia. This is other case in which a huge bladder with keyhole sign was seen. We advanced, we saw the fighting walls of the bladder, the verumontanum, and other tiny hole, but this one is bigger. This is a urethral stenosis or anterior valves, but this is not an atresia because we see an output, although it is small. By ultrasound, this zone here will correspond to the one we are seeing on the fetoscopy and this insinuation of permeable urethra, but we do not know if it is a severe obstruction or which anomaly is it. In this case, we could pass a catheter through the fetoscopy, being careful, and while placing the catheter, an ultrasound was performed. In an epidural anesthesia, catheter of 1 to 2 millimeters. We advanced slowly the catheter, and in the ultrasound, we saw that the ultrasound passed through the urethra till the end of the penis. Once again, the catheter in the endoscopic view and the ultrasound, the catheter in the bladder and the urethra. How is it exteriorized through the penis? So the bladder catheter is correctly placed into the bladder until the penis. And here we have the endoscopic view of the catheter, the penis. Which are the expected complications of this procedure? Transient urinary ascites, always due to the hole made in the abdominal wall, and bladder due to the trocar of the endoscopic procedure, is transient and in 10 to 14 days should disappear. In some cases, we shall have a iatrogenic ureterorectal fistula, which is estimated in 10% due to the direct lesion with the laser in nearby structures. It has occurred in 2 cases out of 20. The baby needed posteriorly a colostomy with repair at 6 to 12 months, but the renal function was normal throughout the pregnancy, and we could prevent the anitramnios. So, knowing it's a severe complication because the newborn need a colostomy for a year, at last the final outcome can be good. And logically, a gestational loss can occur due to premature rupture of membranes or infection, or multiple invasive procedures prior to cystoscopy, and is reported in around 10% of cases. Here in the image we see an ureterorectal fistula. This is the rectum and sigmoids full of urine. That is why it's seen in black. So the urine is passing from the bladder to the rectum and then to the exterior of the body. Our experience is summarized in 20 cases. In one, had a failed surgery. In the other 19, in which the surgery was successfully done. In 3, we couldn't solve the persistent oligohydramnios. And these 3 patients with the other 1 who underwent a failed surgery asked for termination of pregnancy. In the other 16 cases in which the oligohydramnios was solved, one of them had 21 trisomy. And in the other case, we had a premature rupture of membranes, which led into termination of pregnancy. From the other 14 cases that went well, in 3 of them, a sudden oligohydramnios in 3rd trimester was evidence, so the diagnosis of renal failure was done, and they also asked for termination of pregnancy. So from the 20 cases initially treated, only 11 reached term, and from then, 8 nowadays conserve a normal renal function, and 3 underwent renal failure. Therefore, we have 40% of cases in which the fetal therapy allowed to have normal renal function. This will be another type of problem. This will be an ureterocele obstructive dilation of the upper urinary tract. And in this case, we perform a laser in the ureterocele. Here we see the bladder fighting mucosa, and at the bottom we see the image, which is the ureterocele that is obstructing the urethra. So with the laser, we make several holes, and with it, the ureterocele gets emptied, and in that way does not obstruct. Here we can see how it was herniated into the urethra. These are cases of good prognosis because there shouldn't be renal dysplasia at that point. And we have to remember that there are no treatable cases. Bladder with anomalies, with septums. This will be a cloaca. It's not a simple obstruction of the urethra. These bladder that are lobulated, without tension, with some degree of ureter dilation, but there is not a clear keyhole. This type of bladder generally corresponds to a more complex case, with a dysplastic kidney with cortical cysts, so there won't be an indication of fetal therapy. These tortuous urethras with septums enlarged, through a fetoscopy it will be impossible to reach the final part of the urethra. We could try to put a bladder catheter to the fetus, but are complex cases with urethral and bladder dysplasias. If we see an urinary ascites, sometimes can be due to a spontaneous rupture, sometimes if the bladder, and sometimes its calyceal system. And here you can see the important ascites and the enlarged bladder, with its not dense bladder, because some part of urine is no longer in the bladder but in the abdomen. This will impede to perform the correct management. It is not possible to perform fetoscopy because urine is leaving the bladder in a spontaneous way towards the abdominal cavity. In some cases, like this, they have an early onset. It is very probable that this is a urethral dysplasia. So try to imagine the prognosis regarding the abdominal wall, the bladder wall. These echogenic kidneys, these features maintain a normal amniotic fluid because it is 12 to 13 weeks of pregnancy, and at this time, it doesn't depend on the renal function. So once again, the dilated kidneys and the huge bladder that probably damage the abdominal muscles and that doesn't have solution. So in these cases, it's not ethically admitted to try to perform a fetal therapy. These will be the cases that we shouldn't try to treat because are not situations suitable to think in posterior urethral valves. And to end, remember, it is a difficult diagnosis. Sometimes it's impossible to differentiate between posterior urethral valves and urethral atresia. And it is even difficult to distinguish also the primary prone belly, so the selection of candidates for fetal therapy is still being studied. Probably, the cystoscopy is useful to select the cases. In the same cystoscopy, we can differentiate from posterior urethral valves and urethral atresia, something that with ultrasound is impossible. We are now in a point in which the shunt should be abandoned, because we have 30 years of experience and only 25 to 30% of cases will have good outcome. On the other hand, the cystoscopy seems like it has better rates, but we need more experience to avoid the lesions of the nearby structures. The preliminary results are hopeful. Currently, The cystoscopy in cases with posterior urethral valves in an obstructive low urinary tract is a survival surgery. In a significant way, we save the baby because we avoid the oligohydramnios, but the nephrologic or vesical function is still questioned. Whether we achieve to save it or not, so we have to tell the parents that we will save the baby, the life of the baby, in 2 of every 3 cases, and we will save the renal function in 2 of every 3 of those in which the life was saved. Thank you.